Imagine your body's engine is just suddenly revving, completely out of control.
Oh, yeah.
Your heart is hammering against your ribs, and you're just sitting on the couch. Your bones are quietly weakening. You're locked in this constant, exhausting state of overdrive.
It is a genuinely overwhelming physiological state to be in.
Right. That's the physical reality of hyperthyroidism. And, you know, when you look at the statistics, just one cause of it, Graves' disease affects roughly 1 in 200 people.
Which is a huge number.
It really is. So when you or someone you love gets that diagnosis, the immediate desperate question is, how do we cut the fuel line to that engine?
Exactly, because the body is, well, it's effectively consuming itself. And historically, our medical tools to fix that overdrive were highly invasive. I mean, we relied almost entirely on the surgical removal of the gland.
Which sounds terrifying. And that makes the pharmacology of how we treat it today so fascinating. So today, our mission for this deep dive is unpacking the exact mechanisms of antithyroid drugs.
Right, the medications that actually calm the system down.
Exactly. But before we get into how they work, we really need to establish some strict boundaries here. Because when I first gathered our sources for this deep dive, I just assumed the term antithyroid drug was this, broad umbrella category for literally anything that suppressed the thyroid.
Which is a super common misconception, actually. I mean, even among medical students.
Oh, really?
Oh, absolutely. But in strict modern pharmacology, the definition is incredibly narrow. So treatments like radioactive iodine or, surgical excision, they definitely lower thyroid hormone levels.
Right.
But those are ablative therapies. They permanently destroy or remove functional tissue. So they are not classified as antithyroid drugs.
Okay, but what about other chemical compounds? Because the sources mention things like iodine solutions or perchlorate being used in certain situations to turn the thyroid down.
Yeah, so older medical literature might have lumped those together under a functional description. But today, modern pharmacology reserves that specific title antithyroid drug exclusively for one class of medications, which are the thionamides.
Okay, so it's a highly exclusive club. We're talking about just, 3 specific members on this pharmacological guest list?
That is correct, just 3. You have methimazole, you have its prodrug carbamazole, which the body actually metabolizes into methimazole.
And that one's mostly used in Europe, right?
Exactly, mostly Europe and the UK rather than the US. And then finally, you have propylthiosyl, which we generally just refer to as PTU.
PTU, got it.
Right. And those 3 compounds share one precise enzymatic target in the human body. So when an endocrinologist talks about an antithyroid drug, they mean a thionamide.
So we have this hyper-specific, crucial family of life-saving chemicals. And what I find incredible is that we didn't discover them by, meticulously reverse engineering the human thyroid gland in a lab.
No, not at all.
We literally stumbled upon them by investigating farm animals that were eating too many vegetables.
It is arguably one of the most serendipitous discoveries in all of endocrinology.
It's wild.
Back in the 1920s and 30s, agricultural scientists noticed this strange phenomenon in livestock. Animals that were fed heavy diets of cabbage family plants. So rutabagas, turnips, kale, the brassica vegetables.
Right.
They were developing massive goiters, enlarged thyroids.
The researchers knew that a lack of iodine in the soil could cause thyroid enlargement, right? That wasn't a new concept.
Right, but that was the paradox. These specific animals had plenty of dietary iodine.
Ah.
The livestock were totally iodine replete. And that led veterinary researchers to this groundbreaking realization: there must be a naturally occurring compound in these specific plants, like a goitrogen, that was actively interfering with the thyroid's ability to function.
Regardless of how much iodine was present.
Exact.
Okay, so then we jump forward to the early 1940s, and this is where an endocrinologist named Edwin B. Aswood enters the picture, right?
Yes, Edwin Aswood.
He was working at Tufts Medical School. But he wasn't studying livestock or cabbage. He was researching sulfonamide antibiotics, the sulfa drugs.
Which were the cutting-edge infection treatments at the time.
Right. And while doing that, he noticed some of his lab rats were developing enlarged thyroids.
And, most researchers would have just dismissed that as a nuisance variable, like a random side effect interfering with the antibiotic study.
But Aswood is like a detective who gets called to investigate a robbery, notices a weird painting on the wall, and ends up uncovering this massive international art heist.
That is a great way to put it.
He followed the odd side effect.
He really did. He saw a biological mechanism hiding in plain sight. He basically recognized the physiological similarity between his rats and those cabbage-eating farm animals.
Right.
And instead of ignoring it, he realized, well, If a chemical could suppress a normal thyroid, it could theoretically be used to suppress a hyperactive one.
So he intentionally hunted for the molecular structure causing that suppression.
Precisely. He systematically tested a massive library of related chemicals, trying to isolate the exact compound that provided, the most thyroid suppression with the least amount of toxicity. And in 1943, he published a landmark paper introducing a compound called Thyroxole.
And just like that, Graves' disease patients went from facing inevitable risky neck surgery to actually having a pharmacological option.
It was huge. By 1945, this was actively being used in clinics. The clinical shift was just seismic.
But Thyroxole itself didn't stick around as the final answer, did it?
No, it proved a bit too toxic for widespread chronic use. It caused severe gastrointestinal distress and bone marrow suppression.
Oh, wow. Okay.
Yeah, so chemists took Astwood's foundational molecule and refined it. They developed PTU as a much safer alternative, and then a few years later in the 1950s, they synthesized methimazole.
It is wild that the entire modern treatment protocol for hyperthyroidism traces back to a chance observation about cattle, sulfa antibiotics, and just a researcher willing to chase a weird side effect.
It really is.
But to truly appreciate what Astwood unlocked, we need to look at first principles.
Right.
We have to break down how the thyroid gland actually manufactures these hormones in the first place.
Right. So you have to think of the thyroid as a highly specialized, multi-step biological assembly line.
Okay, an assembly line.
Step 1 is iodide trapping. The gland acts like this powerful biological vacuum. It uses a mechanism called the sodium iodide symporter to actively pull iodide out of your bloodstream.
So it's sucking it in.
Exactly. And it concentrates it inside the thyroid cells, literally pulling it against a steep concentration gradient.
Okay, so the factory is basically securing its raw materials.
You got it. Then step 2 is oxidation and organification.
That's a mouthful.
It is, yeah. But basically, once inside, the iodide meets the master machine of this whole factory, which is an enzyme called thyroid peroxidase, or TPO for short.
TPO, okay.
TPO oxidizes the iodide and binds it to a massive structural protein called thyroglobulin.
So TPO is physically locking the iodine into the organic building blocks.
Exactly. And they move straight to step 3, which is coupling. That exact same TPO enzyme takes those newly iodinated building blocks and couples them together.
Oh, so TPO is doing double duty.
It is. And this specific chemical merging creates the final thyroid hormones, thyroxine and triiodothyronine.
Which most people know as T4 and T3, right?
Exactly, T4 and T3.
Okay, so now we have our finished product. But the factory doesn't just dump all of this newly manufactured hormone straight into the bloodstream the second it's made, right?
No, it holds it in reserve. Step 4 is storage and release. The finished hormone is stored in this gelatinous central cavity within the gland called the colloid.
The colloid.
Right. It functions as a massive reservoir. The body keeps weeks' worth of thyroid hormone packed away in this colloid, and it only cleaves it off and releases it into the blood when systemic metabolic demand actually requires it.
Okay, I really want to focus on that specific architecture.
Yeah.
Because if you imagine the thyroid as this sprawling manufacturing plant, methimazole and PTU enter this plant, and their only job is to chain the doors to the assembly line shut.
That's a perfect way to visualize it.
They bind directly to TPO, so the workers are completely blocked from making any new product. But, and this is the crucial part for anyone taking these drugs, they do absolutely nothing to the massive warehouse out back.
Right.
That colloid warehouse is already packed to the rafters with finished, ready-to-ship hormones.
And that structural reality explains the single most common frustration patients experience when starting these medications.
I bet.
Yeah, a patient with severe hyperthyroidism takes their first dose of methimazole, expecting their racing heart to just calm down by the weekend.
Right, because they took the pill.
Yeah.
But their body is still steadily shipping out all the existing inventory from that warehouse.
Exactly. The drugs inhibit synthesis, not release. The assembly line is frozen, but the systemic release of previously manufactured hormone just continues unabated.
Wow.
It reliably takes 3 to 6 minutes for the body to finally exhaust that stored colloid supply.
3 to 6 weeks.
Yeah. Only then do circulating hormone levels drop and the patient actually feels relief.
Understanding that mechanism dictates the timeline. You just cannot rush the biology.
No, you can't.
So the thionamides share that TPO blocking mechanism. But I noticed in the clinical data that methimazole and PTU are absolutely not interchangeable. They have very different pharmacological profile?
Oh, they are structurally distinct molecules entirely. Methimazole is significantly more potent. It's roughly 10 times stronger than PTU, milligram for milligram.
That is a massive difference in raw power.
It really is. And furthermore, methimazole has a much longer intrathyroidal half-life.
Meaning it stays active inside the gland for longer?
Exactly, for an extended period. So from a clinical perspective, that means a patient can usually just take a single methimazole pill once a day and maintain stable suppression.
That's pretty convenient.
Very. PTU, on the other hand, has a much shorter active window. It requires patients to take it 2 or 3 times a day just to keep the assembly line shut down.
Okay, so methimazole is drastically stronger and infinitely more convenient for the patient. It seems like a complete blowout. Why does PTU still even exist in the modern pharmacopoeia?
Well, PTU possesses a secondary mechanism of action that methimazole completely lacks.
Okay.
We discussed how the thyroid factory primarily produces T4, but T4 is essentially a prohormone. Out in your peripheral tissues, like your liver, your kidney-specialized enzymes called deiodonases clip off one specific iodine atom from T4.
To create T3.
Right, to create T3, which is the highly potent, biologically active form of the hormone.
And PTU interferes with that peripheral clipping process.
Yes, at high doses, PTU actively inhibits type 1 deiodinase. So not only does it block the factory from making new hormone, it actually prevents the prohormone already circulating in your bloodstream from being converted into its most dangerous active state.
Wait, if PTU has the ability to neutralize the active hormone currently flooding the patient's system, why isn't it the universal first choice? I mean, that peripheral block sounds incredibly valuable for someone suffering from hyperthyroidism.
It is invaluable, but mostly during a rare acute medical emergency known as thyroid storm.
Okay, thyroid storm.
Right. In a thyroid storm, the hyperthyroid state accelerates into a multi-organ crisis. The heart rate spirals, temperatures spike, and mortality is a genuine threat. We do not have 3 to 6 weeks to wait for the colloid warehouse to empty.
Oh, right. You can't wait a month.
Exactly. We need to bluntly force active circulating hormone levels down immediately. So in that critical care setting, PTU is traditionally deployed.
And looking at the sources, they outline this multi-drug approach for thyroid storm. They use PTU, they use beta blockers to protect the heart, and interestingly, they also administer high doses of iodine solutions.
Yeah, and the iodine administration often confuses students.
I can see why. We just established that iodine is the raw material the factory uses to make the hormone. Giving iodine to a hyperthyroid patient sounds like literally throwing gasoline on a fire.
It absolutely does.
How does flooding the system with raw material actually help calm it down?
It leverages this fascinating biological failsafe called the Wolff-Chaikoff effect.
The Wolff-Chaikoff effect.
Yes. When the thyroid gland is suddenly exposed to massive pharmacological doses of iodine, the internal autoregulatory system basically panics.
It panics?
Yeah, it detects this overwhelming surplus and instantly halts both the organification process and the release of stored hormone to prevent fatal toxicity.
Wow.
It's a temporary paradoxical shutdown mechanism. So we utilize that physiological break alongside PTU to rapidly stabilize a crashing patient.
Okay, so PTU is a heavy hitter for emergencies. But its everyday use was severely curtailed because of, well, a pretty dark side to its safety profile.
Yeah. The medical community's relationship with PTU represents a major historical course correction because from its introduction in the late 1940s all the way into the late 2000s, PTU was frequently utilized as the default first-line therapy in the United States.
So millions of prescriptions over decades.
Absolutely. But then, in 2009, the FDA conducted a rigorous review of post-marketing surveillance data, and the findings were just undeniable. PTU was directly linked to idiosyncratic severe liver toxicity.
Define severe.
We are not talking about a mild elevation in liver enzymes. The data revealed cases of fulminant hepatic necrosis,
Meaning?
rapid immune-mediated destruction of liver tissue. It was causing total liver failure to the point where pediatric patients were requiring emergency liver transplants or, tragically, dying.
Oh my God, how did methimazole compare in that FDA review?
Methimazole can also affect the liver, but the mechanism is very different. It typically causes cholestatic jaundice, which is essentially a backup of bile flow in the liver ducts.
Okay, still doesn't sound fun.
It's uncomfortable for sure, and it requires stopping the drug, but it is rarely fatal and it usually resolves. PTU, on the other hand, was causing necrotic cell death. So as a result, the FDA issued a strict boxed warning in 2009.
A black box warning.
Exactly. Overnight, the standard of care flipped. Methimazole became the undisputed primary treatment.
But wait, if PTU carries a documented risk of literally destroying a patient's liver, why keep it on the market at all for anything outside of an ICU thyroid storm?
Because of one highly specific, incredibly delicate clinical scenario: managing hyperthyroidism during pregnancy.
Oh, okay.
This requires a masterful balancing of pharmacological risks.
Walk us through the variables in play there.
Well, if a pregnant patient requires thionamide therapy, using methimazole during the first trimester introduces a terrifying variable. Methimazole is associated with a rare but distinct pattern of birth defects termed methimazole embryopathy.
What kind of developmental disruptions are we talking about?
It can cause aplesia cutis, which is a congenital absence of skin on the infant's scalp, and more severely, it can cause esophageal atresia, where the tube connecting the mouth to the stomach fails to develop continuously, alongside various facial malformations.
That's awful. And PTU does not trigger this specific embryopathy.
No, extensive data shows PTU lacks that specific teratogenic profile. However, if you prescribe PTU, you are exposing the mother to the risk of fulminant liver failure.
So the physician literally has to choose between endangering the fetal organ development or endangering the mother's liver.
Exactly. And the solution they came up with is a meticulously timed pharmacological relay race.
A relay race.
Yes. During the first trimester, which is the critical window of fetal organogenesis when the teratogenic risk is highest, the guidelines mandate using PTU to protect the structural development of the fetus.
So you absorb the maternal liver risk when the fetus is most vulnerable.
Exactly. Then, the moment the first trimester concludes and the primary organ formation is complete, the physician immediately discontinues the PTU and transitions the mother onto methimazole for the second and third trimesters.
You literally switch the drug right at week 12.
You do. You switch because the cumulative threat of PTU destroying the mother's liver eventually eclipses the now reduced risk of birth defects.
That is a stunning example of precision medicine. The definition of the safest drug dynamically shifts mid-pregnancy based entirely on gestational timing.
It's incredible risk balancing.
The ability to adapt based on that data is incredible. But our sources highlight another severe risk factor that does not discriminate between methimazole and PTU, a complication that applies equally to both, right?
Yes, you're referring to agranulocytosis. It is the most feared complication of thionamide therapy. It's rare, occurring in roughly 0.1 to 0.3% of patients, but it is entirely unpredictable and potentially lethal.
Granulocytosis, that's a sudden crash in the white blood cell count, specifically the neutrophils, right? Your immune system basically drops to zero.
Leaving the patient utterly defenseless against environmental pathogens, a minor throat infection can swiftly escalate into overwhelming sepsis.
From a patient perspective, I mean, if I'm taking a daily medication that carries even a fractional risk of annihilating my immune system, I would demand a standing order for weekly blood tests. I would want my white blood cell count monitored constantly.
And that is a completely rational assumption. I mean, in oncology or rheumatology, we routinely use scheduled laboratory surveillance to monitor for bone marrow suppression.
Right.
But applying that logic to thionamides is a critical clinical error.
Wait, why does scheduled monitoring fail here?
Because of the underlying mechanism of the toxicity. Thionamide-induced agranulocytosis is not a cumulative, dose-dependent poisoning of the bone marrow that you can watch slowly decline over a month.
Oh, it's not.
No, it is an idiosyncratic immune-mediated reaction. The body suddenly generates antibodies that cross-react and destroy its own neutrophil precursors.
Meaning the crash happens rapidly?
It can manifest in a matter of hours. A patient could have a perfectly robust, healthy white blood cell count on a Tuesday morning lab draw.
Okay.
By Thursday evening, an immune cascade has triggered and their neutrophil count is absolute zero. Routine surveillance offers a dangerous illusion of safety because it cannot predict an idiosyncratic immune event.
Wow. So if the doctor's chart and routine labs cannot protect the patient, how do you prevent fatalities?
Patient education becomes the primary life-saving intervention. Clinical guidelines emphasize that patients must be explicitly instructed. If you suddenly develop a fever, a severe sore throat, or painful mucosal ulcers in your mouth,
You stop the drug.
you instantly start taking the medication and seek an emergency blood count. Symptom-triggered evaluation is literally the only effective defense.
You just have to rely on the patient recognizing the biological alarm bells.
Exactly.
Given the sheer unpredictability of these side effects, it makes total sense that endocrinologists are still heavily debating the safest ways to deploy these medications.
Oh, the clinical practice divides are intense, particularly regarding the underlying philosophy of management.
Like what?
For example, when initiating therapy for Graves' disease, physicians must choose between two distinct dosing strategies: titration versus block replace.
Okay, let's define those mechanisms. Titration is pretty intuitive. You start with a high dose to wrestle the overactive thyroid down, and as hormone levels normalize, you slowly taper the dose down to the lowest effective maintenance level.
Right. You are constantly chasing the patient's intrinsic fluctuating thyroid activity, constantly adjusting the dose to maintain equilibrium.
So what's block replace? That sounds like a much more aggressive mechanical approach.
It is. The block replace philosophy argues that chasing a fluctuating gland is inefficient. Instead, you administer a massive, sustained dose of antithyroid drug to completely and permanently shut down the patient's endogenous hormone production.
You just flatline their natural factory.
You flatline it.
But wait, if you completely shut down their factory, they instantly swing into severe hypothyroidism. They'd have no energy at all.
Exactly. So to counter that, you simultaneously prescribe a daily dose of synthetic levothyroxine artificial thyroid hormone.
Oi.
By completely blocking the natural gland and replacing it with a fixed synthetic dose, the physician gains absolute predictable control over the patient's metabolic state.
It sounds beautifully elegant on paper, honestly. Just decouple the disease from the patient entirely.
Mechanistically, it is elegant, but clinically, it proved really problematic.
How so?
Rigorous trials demonstrated that the block replace regimen exposes patients to significantly higher total doses of thionamides for extended periods.
And more drug means more side effects.
Exactly. That increased exposure directly correlates with higher rates of adverse side effects without actually improving the long-term remission rates of the Graves' disease itself. Consequently, the titration method is heavily favored in modern guidelines.
Okay, so the ultimate goal of doing, say, a 12 to 18-month course of either method is achieving remission. The immune system stops attacking the thyroid, you withdraw the drug, and the patient is cured.
That is the ideal outcome, yes. And it occurs in roughly 40 to 50% of Graves' disease patients.
A coin flip, basically.
Pretty much. But the critical debate centers on what happens to the other half, the patients who relapse the moment the thionamide is withdrawn.
The factory engine immediately revs back up.
Yes.
And this is where the source material highlighted a massive geographic divide in medical care, which I found fascinating.
It's a huge divide. If a patient relapses in the United States, the historical, deeply ingrained standard of care strongly favors definitive ablative therapy.
Right.
U.S. endocrinologists generally recommend administering radioactive iodine to permanently irradiate and destroy the overactive tissue, or just referring the patient to a surgeon to have the gland physically removed.
Which guarantees that the patient will be dependent on synthetic thyroid hormone pills every single day for the rest of their life because they no longer possess a functional thyroid organ.
True, but that is viewed as an acceptable trade-off in the U.S. system to cure the hyperthyroidism.
Okay, but what about elsewhere?
Well, if you examine healthcare systems in Europe or in Japan, you find a radically different clinical philosophy. They actively resist permanent organ destruction.
They prefer chronic pharmacological management.
Precisely. European and Japanese guidelines are much more comfortable keeping the intact gland and maintaining patients on low-dose methimazole for years, sometimes even decades.
Wow.
They view hyperthyroidism as a chronic, manageable condition, similar to how we manage high blood pressure or diabetes with daily medication.
It is entirely a question of risk tolerance, isn't it? The U.S. system seemingly lacks tolerance for the rare, unpredictable pharmacological side effects of the drugs, so they prefer the certainty of organ ablation.
Yes.
While the European system lacks tolerance for permanently destroying a vital organ and forcing lifelong synthetic dependency.
And the incredible thing is they are looking at the exact same biochemical mechanisms, the exact same clinical trial data, and arriving at completely divergent definitions of the optimal outcome.
That reality perfectly encapsulates why the pharmacology of antithyroid drugs is such a profound lens for understanding medicine itself.
It really is.
I mean, we explored how a drug's specific molecular target, blocking the assembly line but leaving the storage warehouse intact, directly dictates a patient's agonizing 3-week wait for relief.
Right.
We saw how robust post-marketing data can completely rewrite decades of entrenched prescribing habits overnight to protect the liver.
And we traced the brilliant pharmacological compromise required to protect both maternal and fetal physiology during pregnancy. We literally moved from agricultural mysteries to precision molecular interventions.
It's an amazing journey, and it leaves us with a really compelling final thought for you, the listener, to mull over. If you ever find yourself sitting in an exam room, newly diagnosed with a condition like Graves' disease, and the specialist hands you a definitive treatment protocol,
Yeah.
it's vital to ask yourself, how much of this specific plan is dictated by the universal, fundamental biology of your cells, and how much is simply dictated by the cultural risk tolerance of the country you happen to be sitting in?
It's a great question. Context is always an active ingredient in medical care.
Absolutely. Thank you for joining us on this deep dive. We thrive on untangling the complex mechanics of how the world and our bodies truly operate. Keep questioning the systems around you, and we will see you next time.